Okay, gaveling us back in after the break. Let's do a quick roll call.
Corey Damian.
Here.
Dr. Buhari.
Here.
Andrew Marino.
Present.
Dr. Patel.
Here.
Claudia Mercado. Present. Denise Pines. Here. You have a quorum.
Okay, we'll continue with item number 17 on the agenda, which is a presentation discussion on Black maternal health in California.
Wait.
Oh, did I miss something?
I mean, Renee, I love it.
Sorry, this B. Sorry, I apologize. I got jumped the gun. It happens. And it's so well laid out in my script. Item number 16B, the budget update. I have Renee Milano from DCA's fiscal office. Apologize.
Has to be green?
Yep. Is that? Perfect. Hi, everybody. I'm Renee Milano. I'm the budget manager that oversees the Osteopathic Medical Board. And today I want to thank everyone for allowing me to present the budget unit section on item 16B. First and foremost, I know there were some initial materials that didn't have all of the information due to an ADA compliance transition issue. I hope that everyone does have an updated copy, and they've also been able to update on the website the materials. So I'm hoping everybody has those updated documents. I did also provide printed copies as well. So I'm hoping everybody has that, and I'll be presenting on those materials today. Page 1 is going to be our expenditure projections. They're based off fiscal month 9 actuals, and based off of those, we're now currently tracking about $1.5 million projected in personnel services, $2 million projected in office operating expenses and equipment, and about $3.5 million in total expenditures for this fiscal year. On page 2, you'll find the revenue projections, and this again is based off of fiscal month 9 actuals. And in that, you'll see we're projecting about $3.3 million in revenue this year, and about $99,000 currently in reimbursement. Page 3 is going to be your fund condition statement. It's kind of the meat of the fund. And on this, you're going to be able to track the overall projections of the health of the fund in our out years. To start, we read left to right, top to bottom. So you'll see our actuals in 21-22 begin at about $5.2 million, which includes a $93,000 adjustment, which is a beginning balance adjustment. So that gives you a starting balance in 21-22 of $5.2 million. With that, you also collected a revenue of about $2.93 million. And based off of that revenue and your actual expenditures of about $3.2 million, that provides you a end balance of $4.5 million. With that, you kind of progress into your current year, into the next fiscal year, and begin your balance at $4.5 million. Currently, based off of fiscal 9 FM fiscal month projections, we're projecting $3.3 million in revenue, and you'll just see that displayed there, and about $3.4 million in expenditures. That gives you a projected current year balance, ending balance of about $4.2 million. And then again, that will carry over into our budget year of 23-24. Now, those will be based off of our governor's budget projections, and you'll see that beginning balance at $4.2 million. Revenue was projected at about $3 million, and then we had an expenditure projection of about $3.4 million. With that, we project a beginning balance of budget year, or an end balance of budget year, about $3.6 million. And all of our out years are projected with a 3% growth. That's just based on standard increases, salary and wages, all of those kind of things. So we build in a 3% overall growth, and we do project revenue as stagnant. This gives us a very conservative approach of a fund condition, and even with all of that, you'll see in 25-26 we are projecting a end-of-year balance, or a revenue months in reserve, of 6.4. So that gives you 6.5 months essentially where if the board isn't accruing any additional revenue and continues expenditures as projected, they can still sustain their activities. Now, that's just an overall overview of the documents that we provided, but I'm also available for any questions, and I just want to thank the board for the opportunity.
Thank you. Any questions or comments from the board members?
I have a question. This is Claudia. How does the state budget affect our board in terms of like there being a deficit or a surplus in budget at the state level?
Absolutely, and we are having discussions about that in regard to the general fund. This is considered a special fund, and so while it is its own self-sufficient funding, we do appreciate when our boards and bureaus take a conservative approach and consider the fact that our general fund is having those concerns. However, there's no direct necessary impact. We just want to be very conservative in that approach because the general fund as a whole is also taking a conservative approach.
I guess there's no real concern with our board based on what you just presented, right? If we stay conservative, bring no money, we can still survive for 6.4 months. That's what you're saying?
In 25, 26.
Yeah,
yes.
Projecting into the near future, okay.
In a couple years out, that is the current projection. And I will say there are no immediate concerns. I apologize. I usually end with that to appease some of the questions, but we have no immediate concerns at all with the funding.
And I guess one follow-up, when it comes about, supporting our staff, and let's say we wanted to add more staff because we see an increase in licenses based on our efforts, how are we going to get support for that? Do we just go find our own money to support our staff members, or if we're having a good year, do we come to you and say, hey, we need more money?
That would be something we would start initial conversations with and work with the board on developing. We do have some budget change proposal discussions that are early in the works, likely regarding that additional employee or support that the board is looking towards. And that's something we work with our boards and bureaus on, especially in regards to future years, if there's a potential fee increase necessary, anything like that. And we do keep a very open dialogue with all of our programs to make sure that we keep that consideration as we go forward.
Thank you, I appreciate that.
I think one of the things for us to maybe look at in the future is doing an analysis of other state osteopathic boards and what salaries look like, what amount of staff looks like. Last week was the Federation of State Medical Boards annual meeting, and I met with several other states who have like a fraction of our licensees, but they have maybe 15, 16 employees. So we should look at whether or not, we have not really been operating at the level that we should be operating at, considering what's happening across the country. I could be wrong, but I think it's something for us to look at, and maybe that might be something as a future agenda item that I say at the end.
Any members of the public who are present wish to comment? Nope. Moderator, any members of the public on the WebEx who wish to comment?
Thank you, Mr. Board President. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field on the lower right-hand corner of your screen, or simply raise your hand. We're displaying instructions and we'll give you a moment. All right, I see no requests for comment at this time. Shall I close the Q&A panel?
Yes, please, thank you. And thank you for your presentation. All right, now we'll move on to item number 17, which is a presentation discussion on Black maternal health in California. We have Ms. Pines, one of our board members, and David Rainin from the Department of Public Health, California.
Great.
I think we're going to start our presentation with a video clip. Is that correct, Ms. Pines? Would you like us to go ahead and do that? Thank you.
I mean, the biggest misconception is there something that we are doing? There is something inherently wrong with our body, our makeup, our genes. There's something that we're eating. There's some ways that we are behaving, that somehow these bad habits have put us in a situation for poor maternal health outcomes. And there's nothing that we are doing that is so different than anyone else in this country. The perfect storm is Black women who are dying during pregnancy because of underdiagnosed conditions Black women who are dying during childbirth because they are ignored when their concerns are heard. Black women dying in the postpartum period because they do not have ready access to physicians when they experience postpartum complications.
Baby actually moves with you. They're moving in there with you, okay?
It's not something that we're doing that's any different from anyone else. I really prefer to just say, hey, call it what it is. It's racism. Racism is killing us, right? Your heart can't take it. So we literally die from broken hearts.
They're just doing like a rotation and they're just like trying to find a lock and key, trying to get out of this way, like, you know.
White people say that all the time, that they don't see race. I've never, ever heard a person of color say that in all the years that I've been alive. And so it's obvious. It's something that is 100% weighing on the minds of the families and the community that I serve. And so not acknowledging it does harm, because it's almost like gaslighting an issue that is not okay.
Unfortunately, there was a state senator in a southern state who said, you know, maternal mortality isn't so bad if we don't count Black women.
Louisiana, about a third of our population is African American. African Americans have a higher incidence of maternal mortality. So if you correct our population for race, we're not as much of an outlier as would otherwise appear.
If that was not an illustration of implicit bias, I don't know what ever could be.
Ms. Pines?
So that was just a short clip of a 90-minute film that I produced that aired on PBS on April 10th across the country in response to the CDC's report that revealed some years ago that Black women were dying at a rate of 3 to 5 times or 4 times white women. And that's just the general number. If you go into particular communities, even in New York, that number can be 20 times as much. And so when I heard that statistic as a filmmaker, I just felt like I really couldn't believe that. I personally did not know any Black woman who had died from complications or had experienced any adverse events as they were going through the process of maternity. But I knew that lots of women did exist. And as I started doing this work and traveling the country, because we went to about 4 cities to tell this story, I realized that this is an epidemic that happens to Black women, that they're almost lucky if they survive through the healthcare system. And so dying during pregnancy, dying during delivery, dying 18 months postpartum is just unacceptable in a country where we spend the amount of money that we spend on healthcare. And when you think about birth, a lot of us just simply think like, oh, women just can have babies, that's really easy. We really sort of think that. And so we don't think that this is possible. But it is, it's possible. And it's not just happening to Black women. I always say that, whatever happens to like the general population, that Black people is always exponential for them. So if you saw for them, you actually saw for everyone else. And so I wanted to be able to tell the story to the way I see filmmaking. I always do social justice films. So the way I see them is so that they're usable tools, so that whoever is the watcher of it either is creating awareness, looking to create an awareness, oh, I didn't know that this existed, or those inside of the problem creation sort of can identify themselves and see what it is they can do to change. So a couple great things is happening with this film outside of it broadcasting nationally around the country. We showed it at the UN in Geneva. I'm in talks with the White House right now for it to be seen by the First Lady. But we are working with AACOM, so they're the accrediting arm of the osteopathic schools, to make this film a mandatory of one of their 10 modules that they have around health equity. So that's one thing. So this now will get medical students. Last week when I was at the Federation of State Medical Boards, the Federation creates CME programs, and one of the officers overheard me talking about the film and came to me and said, we want to turn this into a CME. So this is filmmaking, honestly, at its best, right? This is not just, oh, that was sort of nice, but now we can actually create impact. I'm also partnering with the AMA. We just created shorter clips, so we pulled some footage out where we had a lot of physicians and CEOs of hospitals talk a little bit more frankly. And so we have a 12-minute clip for clinicians and a 12-minute clip for healthcare administrators. So as the Dobbs decision puts more women, across the countries, especially in particular states, into an already broken system, we're going to see these numbers become exponential in a very short period of time. The unfortunate part that I see about regulations that get passed that doesn't have money attached to support what is going to come into the system is just bad legislation, right? That's just bad legislation when you make decisions like that. So this film, shines a light on this complex issue, right? There's no one answer to it. Yes, it's racism. Yes, it's how the medical system is designed and how things are reimbursed. It's, hospitals that don't have enough resources to even keep their OBGYN departments open. I sit on a hospital board that their maternal ward almost was closed. And the people in that community would not have had a place to go if they didn't get bailed out, honestly, from philanthropic dollars. A lot of times we see, when I look at the easy answers, some of the easy answers is, doulas as advocates for these women, or more midwives. And those are answers, but those aren't the only answers. I think one of the biggest challenges is that physicians do not listen to these women at the most critical point of which they need to be heard. During these really critical moments, they don't have wait-and-see days. They have maybe wait-and-see moments, maybe wait-and-see a few hours. That becomes that critical when there is a complication. So that's what this film does. It's called Birthing Justice. People can still see it. It's streaming on PBS right now. It did really well, so a lot of them are rebroadcasting it in this month and in June. So I wanted to bring this issue. I'm also talking at the Medical Board of California in August, and I'm talking with a couple other boards in the same exact manner for us to recognize that this is a problem, that this problem exists within the healthcare system, and it does exist directly aligned with physicians. So thank you for the opportunity to be able to talk about it and show a small clip from the film. And now we're going to have a representative from the Department of Family Health, David, come and speak and present on what's happening specifically in our state. Thank you, David.
We good?
Either one works.
Okay. Everybody can see and hear? Yes. All right. Great. Thank you for your patience there. Thank you for this opportunity. Good afternoon to the board. I'll be sharing information about maternal mortality and morbidity in California, looking at some of our data and some actions we're taking with respect to those data. After seeing that amazing video, and I've seen the full 90-minute version, it's incredible. You all should watch it. I do want to remind you all that while I'm talking about numbers, these numbers represent real people. And so when I talk about cases or deaths, we're talking about really tragic events, and we cannot continue to be okay with that. So, let's see, how do I'm having trouble advancing.
You should see it. This is the moderator. You should see an arrow at the top of your screen that you can, if you're looking in WebEx.
Oh, thank you. Thank you. Thank you for your help. Yeah, so sorry about that. Just quickly, our roadmap for this afternoon, I'll be talking about maternal mortality and morbidity, defining some terms, talking about our surveillance and quality improvement efforts. Also, going over what actions we're taking programmatically. I'll provide some contact information, and time permitting, we can have some questions and discussion. I want to start with maternal mortality, and there's a QR code there. If you want to scan that with your phone, it'll take you to a landing page where there's a whole lot of additional information from our division on maternal mortality. And I want to start by acquainting you with some terms. There are two terms that I'll be referring to quite regularly, maternal mortality and pregnancy-related mortality, and I want to differentiate between the two. So if you look at this figure, the circle, the dark blue circle that corresponds with the dark blue rectangle, that's what we generally refer to as maternal mortality. And this is a measure that's in wide use. It comes from the World Health Organization. It's also used by the National Center for Health Statistics. And what it is, it's a statistic that describes deaths during pregnancy and up to 42 days after the pregnancy ends. And these are deaths related to the pregnancy itself. So that's a very commonly used metric. States report it. It's reported nationally. It's reported internationally. You hear it on the news. But I have to tell you, it's a little bit of an unreliable measure. There's some underreporting in places. There's overreporting in places. And so what we in California are trying to do, and this is following the federal government at the CDC, is we're trying to have a better accounting of maternal deaths. And so that takes us to the pregnancy-related mortality. And that is that medium blue circle that's just above the maternal mortality circle. And what this represents is deaths during pregnancy and up to 1 year after pregnancy that are related to pregnancy. But how we get there requires us to look at pregnancy-associated mortality, which is that grayish circle, the largest one. And that is deaths due to any cause up to 1 year after pregnancy. So what we do is we assemble the pregnancy-associated cases, and we go through a process to determine which are pregnancy-related. Again, that's a better metric, pregnancy-related mortality, than conventional maternal mortality. And so I'll be referring to those two and drawing a contrast to try to just let you know that there's some issues related to reporting, and we have to all be aware that sometimes the problem is even worse than what gets reported. Just to show this a little bit different way, this is a tabular form where it talks about maternal mortality on the left, pregnancy-related mortality on the right. Again, the time frame for the MMR is up to 42 days postpartum, whereas for the PRMR, it's up to 1 year postpartum. The data source for maternal mortality is death certificates only, and again, there's some reliability issues there with data quality. And then we define it using those data with ICD codes. In contrast, the better measure, the pregnancy-related mortality ratio, utilizes many different sources of data, vital statistics files, including birth, death, and fetal death data, hospitalization data, medical records, coroner and autopsy records, and all this information is gathered together and fed to an expert committee, which then does the determination of pregnancy relatedness. And so, again, these are the two measures that are in use. The maternal mortality ratio is widely used, but there are some reliability issues. So you'll be seeing from the data I present the pregnancy-related mortality ratio, which is a better accounting of maternal deaths. So I'm going to tell you how we arrive at that pregnancy-related mortality ratio. We do that through surveillance, where we're looking at the burden of the disease. We're trying to describe, how it impacts our population. And our surveillance, which is done through rapid cycle reviews, is referred to as the California Pregnancy Mortality Surveillance System, or PMSS. And it was initiated in 2018, again, to provide a timely and accurate pregnancy-related mortality data. The first deaths that were reviewed were from 2008, and to date, since 2018, we have done rapid reviews of over 1,000 deaths. Again, because the ratio is, the maternal mortality ratio, rather, it's based on death certificate data, and it's not reliable. We in California had some underreporting, and I'll show you some data on that shortly. Perhaps some of you are familiar that Texas, in contrast, had some overreporting. So you can see, in terms of the direction and the magnitude of the deviation from the true number, it varies from place to place. So PMSS aims to identify the cause and timing to death, to determine if the death was related to pregnancy, and so therefore it serves as an efficient method for maternal mortality review with sort of enhanced methodology. The other thing it does is it informs our in-depth reviews, and our in-depth reviews I'll talk about momentarily, where we really get into some of the causes and prevention opportunities for these deaths. Schematically, this is what PMSS looks like. You can, if you start at the upper left corner with the death records, what we do in California is we do linkage with birth records and fetal death records. But of course, not all pregnancies result in a live birth or a fetal demise that has a fetal death certificate issued. So we also look at patient discharge data, emergency department data, ambulatory surgical center data, as well as some information that is on the death certificates. And with all that linkage and those sources of information, we develop what we call a pregnancy-associated death cohort. Within that cohort, we look at pregnancy status, and we look at timing relative to the end of the pregnancy. And then we validate that information by using coroner reports and medical records, which we procure. That's in the center there in that green rectangle. Below that, in that light blue rectangle, you can see some of the exclusions. Those are exclusions based on a standard methodology, again, following the federal government's lead to the CDC. Once we have that pregnancy-associated death cohort, we share that with our expert review committee, and that review committee then determines pregnancy-relatedness to say, in fact, yes, these pregnancy-associated deaths were related to pregnancy. Others turn out to be not pregnancy-related or unable to determine. But once we know those pregnancy-related deaths using this methodology, that forms the data for our surveillance. The other thing that does, in addition to describing the burden, is it informs our quality improvement efforts. And so what we do, instead of rapid cycle reviews, where we're only looking at cause and timing and pregnancy-relatedness, we do in-depth reviews where we look at many more, much more information to determine causes and quality improvement opportunities. And that in-depth review process is a program we call the California Pregnancy Associated Mortality Review, or PAMR. PAMR is set up to prevent pregnancy-related deaths and to eliminate racial, ethnic, and other health inequities. It aims to identify pregnancy-related deaths, their causes, and preventability. So that's the enhanced part of this, their causes and preventability. We also look at contributing factors and prevention opportunities at many levels, including the patient, provider, facility, and system levels, but also more broadly in the community level. Again, we're looking at deaths out to a year postpartum. So at some point, the postpartum visits typically go 6 weeks. Women are dying much longer than that, and from causes related to pregnancy. And so we need to engage the community and see what services and what assets and resources are available to serve these women, so that as we create real change, when these same kinds of circumstances arise in the future, lives are saved rather than lost. So again, we're working to improve maternal health outcomes. PAMR was established in 2006 after observing a rapid increase in maternal mortality. So we said we can't we can't be okay with that, so we have to figure out what's going on. So the first deaths that were reviewed were from 2002. Since that time, we've done multiple phases of PAMR. 3 completed phases have resulted in over 600 deaths being reviewed by different expert review committees. The first phase was obstetric and medical causes. Then we shifted over to pregnancy-associated suicide, and we switched gears once again most recently and completed an obstetric hemorrhage review. All of these were statewide, and again, over 600 deaths were reviewed. From some of those early reviews, we took the information that emerged from the review process and worked collaboratively with Stanford University to develop some maternal quality improvement toolkits. Perhaps some of you practitioners are aware of them. There are toolkits related to CVD and hemorrhage and hypertension and sepsis and a few others. Again, this is kind of a data to action approach here. Currently, with PAMR, we have 2 committees that are ongoing. One in Southern California, which is a population-based review of obstetric and medical causes of death. And secondly, we began a review committee focused on COVID-19. So these are pregnancy-related deaths from COVID-19. To date, with these ongoing 2 committees, we've reviewed 120 deaths so far and counting. So for the in-depth reviews, we're up over 700 reviews. And again, as I mentioned earlier, with the rapid cycle for surveillance purposes, we're over 1,000 reviews. So because we employ these, we impanel these committees, they're voluntary. We have these different review committees, both the rapid cycle and the in-depth. We have expertise from clinicians and from community members. And as you can see here, it's a broad range of expertise because we recognize that there are many opportunities, many leverage points for change, many services and many resources that are required to really create real change here. And so we're drawing on the expertise of all these individuals. When we go through the committee process, there are several guiding questions. For both the rapid cycle and the in-depth, we ask, was this death pregnancy related? And what was the underlying cause of death? For the more in-depth review, where we want to know sort of the drivers of these deaths and what can be done about it, we ask, was the death preventable? What were the contributing factors to the death? And we ask these questions at the patient, family, provider, facility, system, and community levels. We have begun utilizing a health equity framework and using a lens where we ask, did discrimination contribute to this? And that's been very interesting, enhancement to our work. And then because of COVID-19, since 2020, we've been asking, did COVID contribute to the death? And then finally, a guiding question for the committee is what specific and feasible actions might have changed the course of events? In other words, what's a leverage point for change here? Ultimately, we take this information, we look for emergent themes based on the deaths in the aggregate, and we work with the committee to develop specific and actionable recommendations. Again, the idea is data to action. And our recommendations take the form of who should do what and when. And again, we're concerned about all levels, from patient and provider through the community. And we're also concerned not just within the childbirth experience or the early postpartum period, but all the way out for a year postpartum. So, having now described the committee work that we do, both rapid cycle and in-depth, I'm going to get into some data here, just so you can see some of the numbers. And again, as I mentioned, remember, we're talking about real people here. So this first slide with data, this does show the MMR. Now remember, I described this as being an unreliable measure, even though it's widely reported. And a couple things I want you to take away from this first graph is when you look at the purple line toward the top of the graph, you see that the United States maternal mortality ratio, the trend line over time, has been on an upward trend, has an upward slope. It moves around a lot because maternal mortality is a relatively rare event. And so a few deaths 1 year more or less will cause the trend line, the slope of that line to shift a little bit. So the first point then is that at the United States level, the MMR has been having this upward trajectory, especially in this most recent 3 years, where you can see the slope of that line going up quite rapidly. If you look at California's MMR, that's the lighter blue line with the triangle markers. Number one, it lies below the U.S. line. In about 2008, that's when we started our work. But I have to just caution you that I told you earlier that that these data were a little unreliable. There was some underreporting there. So when you see that lower valley there, around 2013 to 2017 or so, we know for a fact that there was some underreporting going on. But as you can see, in recent years, there's this upward trend. So again, these are not that reliable, but you see these in the news, you hear about these, and so what I want to do is just put out that cautionary note and instead share what we refer to as the gold standard data, the PRMR. These are better data. Again, you can see the California line, which is the blue, below the U.S. line, which is the purple. I do want to make a note that these are not perfectly comparable because the methodology used at the national level is slightly different than the methodology used in the state of California. What we do here is we use a few more reporting sources so we can capture more deaths. We also employ these committees, as I've mentioned, whereas at the federal level, they use a couple of medical epidemiologists, not a full committee. Again, slight methodological differences, mostly comparable, but not exactly. As you can see, it's mostly a slight increase until what is the pandemic. We have seen maternal mortality go way up in part because of the pandemic. If you look at the 2020 data point, the 18.6 deaths per 100,000 live births is what our true data point is. If we wanted to, or because we were curious about COVID, what impact that had, we removed those just for a comparison data point. You can see that it goes down to 15. So that's, that's sort of a harbinger, perhaps, of what we're going to see in future data because of the pandemic. So it's even more reason to double down on what we're doing. If we look at pregnancy-related deaths by cause, you can see the number one cause is cardiovascular disease. About half of those are cardiomyopathies. Hemorrhage is number 2, infection is number 3, and as you can see in that horizontal bar, 3% of those were COVID. But keep in mind that this is these horizontal bar charts are for 2012 to 2020, so those COVID deaths were only 2020. That's how much that's impacting infection as a cause of pregnancy-related deaths. When we look at these same causes by timing, this is important when you think about what are our intervention points, where can we make a difference. So the darkest blue is during pregnancy, the medium blue is during delivery and early postpartum, and then we get into the grayish color is the up to the 6 weeks, and then beyond that, the light gray all the way to the far right, that is that represents out to a year's time. So if you look at CVD, for example, you can see that a third of the cases happen, after the usual postpartum checkups are over at 6 weeks. So that's a key piece of information. In contrast, if you look at hemorrhage, you see that 3/4 of them are happening at the day of delivery or shortly thereafter. And so that's a different point of intervention. That's more in the clinical setting because that means that this highly at-risk situation is still under the direct care of medical professionals. Because we are concerned about social determinants of health, we utilize the California Healthy Places Index. Perhaps you're familiar with that. It's a way to sort of gauge the health of communities, taking into account a number of things, including neighborhood characteristics, educational employment data, other social determinants, transportation, a whole series of data. And what that does is it will classify a given geographic area as being advantaged or not And so we represent these data along 4 quartiles. And what you can see over these three time frames, the pregnancy-related mortality ratio was lowest in the most advantaged. And that's kind of common sense, but it's really good to see this quantified. And you can see that this has not changed over this, the span of time here. And in fact, when you look at the most recent data, the most advantaged, the data point is 9.2. In the least advantaged, it's 18.9. So just where you live, nothing else, there is a twofold increased risk of death from maternal mortality. And so that's something we have to think about. It's not just what's happening in the clinical care of these individuals, it's what's happening in the community, and that's where we can also work to create change. This gets at some of what was discussed in the birthing justice video. These are the disparity ratios between Black birthing individuals and other racial ethnic groups. Across these 3 time periods, you can see that the red vertical bar here, which represents Black birthing individuals, is just by far and away much higher than any of the other groups. I mean, it's startlingly higher. Earlier on, it was about a 4 to 5-fold difference. In 2015 through 17, it actually went up. The disparity was 5 to 6 times. And it has narrowed slightly. The most recent data suggests 3 to 4 times. This is not unique to California. We see this across the nation. And again, watch that video. There's so much good information in that about this very information, and we just can't tolerate this. I want to shift gears a little bit to maternal morbidity. Severe maternal morbidity is the measure we use. It's a composite measure. It comprises a wide range of pregnancy complications that result in significant short or long-term consequences to a woman's health. So she survives, but she has severe consequences. The CDC developed the definition, which includes 21 hospital discharge procedures and diagnostic codes that indicate a potentially life-threatening condition or complication. So some of the diagnostic codes include sepsis or kidney failure. An example of a diagnostic code would be, a procedural code would be a hysterectomy. So we track this using discharge data that we get from the state of California, or for the state of California. And what you can see in this trend line over time is that since 2008, there's been a steady increase up through 2020. In fact, while it looks like a really sort of gradual increase, if you look at the magnitude, the 2020 data point is 104.4 cases per 10,000 delivery hospitalizations, which is more than twice what it was in 2008. The leading indicators, as you can see here in these horizontal bars, the first one is DIC, which is abnormal blood clotting. Secondly is sepsis. Third is acute kidney failure. Acute respiratory distress syndrome is next, and then hysterectomy, which is a procedure code, narrows out the top, finishes out the top 5. Again, with the disparities, we see that the non-Hispanic Black rate is above and consistently above the rates of the other racial ethnic groups. In fact, as of 2020, the SMM rate for Black women was nearly twice that of white women. This is an alarming gap, and it continues to persist. At the same time, severe maternal morbidity is going up for all groups. It also varies geographically. We can see here a map of California's counties where the darker orange color represents a greater burden of severe maternal morbidity. And as you can see, several Northern California counties had rates above the California average. Those include Humboldt, Sonoma, Napa, Yolo, Sacramento, Alameda, and Santa Cruz. So that's kind of the committee work we do, the data we track. And so as I come to a conclusion here, I want to just give you a glimpse into some of the programs and services we do within MCIH. We have kind of two buckets of programming. One is related to infrastructure and capacity building. And you can kind of glance over those for yourselves. I'm not going to go through any detail in those. But the other kind of bucket of programming, and these are a little more germane to this conversation, are the programs and services for vulnerable populations. And specifically I'm going to highlight the bottom two there, the Black Infant Health Program and the Perinatal Equity Initiative. First, the Black Infant Health Program. This is a program that has two kind of complementary models that run concurrently. There's a group model where Black birthing individuals get together, and they go through various curricula and and they work on different strategies together. And then the other part of it, the other complement, is that there's individual sort of coaching type of life planning, where a given individual will be working with a case manager to complement the group model activities. So it's kind of a two-pronged approach, and it's very effective. And those who are eligible are 16 years and older, they're pregnant, or up to 6 months postpartum at the time of enrollment, and it's regardless of income, so anyone can participate. What we see from this program, which by the way has been around more than 3 decades, is that participants report having a better understanding of effective strategies to manage and address stress. They have stronger positive connections to their heritage and to the Black women in their community, and they have increased empowerment to make behavioral changes that lead to healthier lives. So Black Infant Health, I believe it's operating in 14 counties that represent 90% of the Black births in California. A few years ago, to augment a lot of the work that was happening in BIH, the Perinatal Equity Initiative was launched. This program serves BIH communities in need of additional supports, including doula services, group prenatal care. There's a fatherhood or partner related services. There's pre and interconception care services, midwifery, and provider training related to respectful care. And so through PEI, which is relatively new, we're tracking Black women with full-term pregnancies. We're tracking fatherhood participation in both prenatal and postpartum. We're tracking access to mental health services. And finally, we're tracking doula involvement and relationship with the medical personnel. So some good work going on in response to the data. Always we want to have science driving the programming that we do so that it's evidence informed. Beyond MCAH, Maternal Child and Adolescent Health, where I work, there are other CDPH programs that promote maternal health. This is not a complete list, but I wanted to just lay out some of these programs. These are collaborators of ours in our division. And then finally, just note that other departments, for example, Department of Social Services, Department of Healthcare Services, they also, of course, work to improve maternal health. Contact information is here. I also want to encourage you to use the QR code to get even more information. I want to highlight that Karen Ramstrom, probably some of you know her. She is a DO. She is our Chief of Maternal and Infant Health, and so she is heavily involved on the program side. And thank you. One more QR code. This is for data dashboards. If you're a data person and you want to get more information on a lot of health status indicators related to MCAH, that's the place to go. So thank you for your attention, and if there's time for questions or discussion, I'm open to that.
Hi, this is Claudia. Just wanted to point out that the QR code, I think you have to give us permission.
I have to give.
It says the QR code campaign has been disabled for.
It may be our Wi-Fi. I don't know.
Oh, the Wi-Fi. Okay.
Okay. So those of you who have the slides, when you're on your own, away from the networks here, maybe.
We can try that.
But thank you for a great presentation.
Yeah, that was a very nice presentation, and thank you, Denise, for bringing this forward. I think these are very important topics, and hopefully the goal is to improve these outcomes, but you have to bring them to light first. quick question about the data. What's the lag time on the data collection for some of these things?
So that's a great question. It varies based on how rigorously we are, we call it sleuthing, you know, how rigorously we're going after the data. A number of our sources of information come from hospitalization data, which are reported through its Healthcare Access and Information, formerly OSHPD. And those data take a little bit longer than some of our vital records data. So there's some lag time built in there. Additionally, when we have to procure medical records and coroner reports, that varies by the person providing. You know, the coroner system in California is, you know, different. Some are sheriff coroner, some are, you know, pathologists. It's just, it varies. So the personnel varies, the process varies. But that's not really a answer to your question yet. I'm just saying why it takes.
That's why, yeah.
What our goal is to be able to fully review a case, going through all those processes I described within 2 years of the date of death.
Mm-hmm.
So provided that we can get access to all that information, which is out of our control, we can request it, but getting it, you know, so, but generally we hit that mark pretty well.
Okay.
So 2 years after the date of death. So.
I just had a question. So is it like a case of negligence from multiple people that are providing health services to African American women? So it sounds like it's the system that's failing us, not individuals? Or is it a combination of individuals and system that seem to not be doing the right thing?
I mean, I'm sure Denise has a better answer than I, but I can tell you that what we see in our data, it's at every level. It's, you know, it's a provider, it's a facility, it's a system, it's the community, it's, you know, it's even, you know, in some cases, it's even family, because, I mean, it may be, you know, we did a review on suicide, right? And so there's a lot going on within a family where the end result is a pregnant woman being, you know, brought to the point of where she wants to take her own life. I mean, there's a lot going on there. So there are all sorts of points at which, you know, there's room for improvement, or, you know, the other side of the coin, there are failures. So no, it's not right to just focus only on one level, one layer. There's so much going on here, which feels a little overwhelming, but at the same time, I think it kind of broadens our perspective, so we realize there are many opportunities to intervene. So we have to recognize that, and we have to work accordingly. And I'll ask, you know, Denise if she has more on that than I do, I'm sure.
I think, I mean, to, you know, really say it simply, I think that these women, Black women, are just absolutely not valued.
Mm-hmm.
So if you're not valued, it doesn't matter what point of the spectrum you're being impacted, right? You're just not valued. And so I don't do anything extra. So we don't improve the facilities of where they're going. The doctors don't listen, or, you know, or become dismissive. The reimbursement is so low, you can't get quality doctors to serve in the areas where these women are, right? So it's, you know, so to David's point, it's not just one thing, it's just like so many different points. And as you heard, they've had programs in place for, what, a decade? And the numbers are still staggering, right? So that, you know, we have seen a little bit of improvement in this state when, you know, a large coalition had got together through partnerships with Stanford, and we were starting to see people like recognizing, the hospitals recognizing, the community seeing what it needed to do and to help, physicians looking at their role. But then, you know, something kind of came unglued along that process, and we started seeing the numbers go up. I think just before COVID, like we were looking, going, hey, what's happening here in 2018, 2019, and then COVID, and it sort of took the, sort of the light off of this for a little while.
Yeah, because I guess my first impression was, how does the media also play into this epidemic like you described it? And I think this idea of like the strong Black woman, right? If you're complaining because you have pain, somebody just says she'll be all right, right? This, I think at a national level, it's a matter of national security because you're putting people at risk because the media is portraying them to be strong and brave, but we all are human beings and we all need health care the same way. So I don't know if that plays into it when you talk to the White House, but I think at a national level, we got to change that image because it affects all of us. I mean, just my thoughts.
So I think just the fact there's much more discussion in the media now. This has been going on for over 30 years. These numbers have been going up. They've been really, really high for a very long time. And I probably would say that we first started seeing articles come out about this maybe 4.5 or 5 years ago. And then there's just been more and more and more. And, doing films like this also helps to elevate that. There's another film out called Aftershock, where it looks at what happens when these women die. The baby survives, and now, what was a family unit is no longer a family unit, and what is, sort of the aftermath. So that you can understand what happens when you, like, we see this, David started off by saying that I'm going to refer to these numbers, but these are humans. What happens to that human and that human's family and that community that that person was a part of? So we just have a lot of loss that ends up happening.
Just final, another comment. I was reading that in terms of the medical system, it's not a good investment to invest in, you're talking about infrastructure and medical facilities for children, like Children's Hospital, for example. I think even those facilities are really rare, and they're only based in certain communities that have philanthropic monies behind them. Is that something that you're seeing as part of the problem, where the medical insurance companies, or maybe let me see what I can try to say. I guess what I'm saying is, in terms of infrastructure, are the insurance companies and the medical profession creating this problem by not investing in women and children's health care because they don't see it as a way to make money? Maybe Terry, I think she's nodding. I think she understands what I'm trying to say.
Yeah, maternal health, deliveries don't make money. Bottom line. I mean, healthcare is a business, and if this is a loss leader in my sort of structure, I'm not putting investment into it. I'm not really hyper concerned about it. I'm making decisions that may not be the best for the patient as a result of that. So for example, you can't really predict that the woman's going to have the baby on, this day. But the way the hospital is set up, like, they need to be able to kind of get you in, get that baby delivered, get you out. I need that bed back, right? So lots of C-sections, we can even see the point of which C-sections increased, right? That were unneeded, and some of those C-sections have caused death.
They're very invasive.
Yeah. So when we say the healthcare system, I look at that from, a capitalist perspective, that it doesn't make money. Medicaid or Medi-Cal in our state doesn't cover it effectively. So those are really like the system problems, right?
Thank you for that.
David, great presentation. I do have a question in terms of underserved areas, like licensee population. Was there any studies made on that to correlate, to eventually get the stats? I mean, they're remarkable in our eyes, and does any of that correlate to underserved areas? We have an expedited process for our applicants in that area, and so I just wanted to see if there were some studies made with that in mind.
So on the mortality side, it's such a it seems weird to say that it's such a rare event, but it is. It's the worst outcome you can have. It's so tragic, but in terms of just sheer numbers, we don't have numbers that permit us to look sort of below maybe a regional level. And if you do follow some of those links I provided, you can get at some of our reports. But yeah, you can see regional differences, and I'm sure if you were to overlay, provider shortage data on that, I'm sure that there would be an association there. Morbidity, on the other hand, there are about more than 4,000 cases of severe maternal morbidity each year, and I know that the same would be true if you looked at underserved areas. You would see this. Part of it is you also have to think about not just the number or distribution of providers or facilities, but also how they're equipped, right? So they have to have certain assets in order to provide the right care for high-risk individuals. You don't want a high-risk pregnancy going to the local community hospital just because it's close by, or maybe, she was born there, so she's going to have her kid there, right? If she's high risk, that's not where she ought to be giving birth. So that's another consideration. And so you get at provider education, you get at patient education about where people should be delivering if they're high risk, right? So that factors into it too. But yeah, certainly. And again, I encourage you to look at some of our reports online where some of this information I shared is in greater detail, including some of the geographic disparities and other things like that.
Thank you very much. It's a very nice presentation. Any comments from members of the public that are present? I believe we have one. And just please state your name. There's a little gray button on the base of the microphone. There you go.
Thank you. Denise Tugade with SEIU United Healthcare Workers West. We represent 100,000 allied healthcare workers across the Western region, and want to thank the board for making space for this really important, nuanced topic. We disproportionately are made up of, direct patient care providers. Disproportionately, that is women of color, and so they are not only, care providers, but they are people who have lived these traumas, and so they want to be part of the solution. And so we have a very active African American caucus with a subcommittee on maternal health care that is particularly active in these issues. And so you come here wanting to be a partner on the care team on these issues. We've been working closely with HCI on data as well, because we think that that is first and foremost one of the really critical first steps of how do we understand the problem. And so, to that point, we have been working with them to get facility level data on sepsis management, C-section birth rates, VBAC, for, vaginal birth after C-section, time in the ED without being seen, and other really critical quality measures, and have that stratified by race, ethnicity, gender, and other, vulnerable population markers. And so, again, thank you so much for raising up this important topic, and a particular thank you to Board Member Pines for your work.
Agreed. Any members on the WebEx? Moderator? Members of the public?
Thank you, Mr. Board President. I've opened up the Q&A panel. If any member of the public would like to comment, please type comment using the field in the lower right-hand corner of the screen, or you may simply raise your hand. I do see some raised hands, so we'll start with Monique Himes. And Monique, you should be able to unmute yourself.
Hi, I just want to say, David, thank you for that presentation. It was really great. I am Monique Himes. I'm a volunteer with Consumer Watchdog. Malachi, my grandson, died tragically from medical negligence. Malachi died because his mother's clear-cut complications from preeclampsia were ignored. Malachi was forced to face a post-mortem C-section. Had his mother been given basic treatment for preeclampsia, Malachi would be here today, excuse me, and we would have celebrated his 4th birthday. I'm completely offended that our public board member, Denise Pines, will bring the issue of Black maternal health to this board while she sat here and listened to us discuss how our baby of color is denied his right to an investigation. It is one thing to be the executive director of a documentary on Black maternal health, but it is another thing to bring that issue to this board when you know our baby's rights are being denied. How do you possibly think that anything can be done without the maternal health crisis in this state by denying dead babies' rights? Every woman deserves a beautiful birth story. I mean, every woman and baby deserves to survive their pregnancy and delivery of their baby. If a baby dies from negligence, then this board must treat that baby like the human being he was and grant him the investigation that you are required to conduct in the case of a death of a patient. We demand babies' rights from this board. Thank you.
Next, we have Maria Abera. You should be able to unmute yourself, Maria. And Maria Ibarra, your last name's cut off. You should be able to unmute yourself if you see a prompt. There you go.
There was a little delay. Thank you again for that presentation. That was really informative, something that we all know about already. I am Maria Ibarra Navarrete. I am from San Jose, a volunteer with Consumers Watchdog. I am a member of the volunteer team of advocates who works on regulatory board reform, maternal health issues, advocacy, and education about our medical negligence. As a member of a team, I support my fellow team members. I join my maternal health advocate colleagues by voicing my concern about a public board member discussing Black maternal health issues. When this board continues to ignore and close consumer complaints filed on behalf of the babies of color that have died or suffered egregious harm, we will not begin to address the maternal mortality and infant mortality crisis in this state. This board continues to ignore and close complaints filed on behalf of the babies, completely ignoring the special statute for minor children, where the statute for minor children does not begin until the child reaches the age of 18. I leave this board with one question. What would you do if this was your mother, sister, daughter, wife, or child, a victim of medical negligence? Thank you.
Our next comment is from Tracy Dominguez. Tracy, you should be able to unmute yourself.
Can you hear me?
Yes.
Okay. Well, David, that was a good presentation, but let me tell you, it's not there for Latina mothers. We don't get the resources that you offer. So that needs to be a change. That's when I started the Save a Mom, Save a Family Foundation in my community so that Latina mothers could get the resources they need because they're not available. So that needs to be looked into. And it is Latina Maternal Health Awareness Month. I have fought for it, and we are dying, and we have a lot dying in our community. But anyways, I'm very emotional because it's my daughter, Demi Dominguez, and my grandson, Malachi De Leon. I'm one of the persons that you guys are talking about in all those numbers. So this really made me very emotional to see this and to be left out as if she didn't matter because she was a Latina, a strong Latina, educated Latina, graduating from college a month before she started having symptoms and got ignored and had medical negligence and lost her life. But anyways, board member Denise Hines, as a public board member, we expect more from you. As a public board member, minimum you should is discuss the maternal health concerns of all women of color. As a public board member of California, you did nothing to address this maternal mortality crisis in our state. As a public board member on this board, all we want is equitable enforcement process. You have listened to our pleas for our babies of color that are being denied basic rights of an investigation of their death from a maternal death. But you say nothing. Where is your outrage for the babies that have died due to maternal negligence? Denise, you truly are not concerned about this issue. When will you demand an investigation into why babies who are dying to maternal negligence and are being denied these investigations of their own deaths? And why is this board denying babies the exception of statute of limitations to minor children? If you care about this issue, you would demand that our baby of color would not be considered a fetus. He was 5 pounds.
15 seconds.
I'm sorry. I'm very emotional. I'm sorry. But would be referred to as a beautiful baby who graced this earth for just a brief moment, who earned every right upon their birth. I am the mother of a daughter who lost her life. I live it every day. My family lives it every day. Thank
I'm
you.
sorry.
Thank you.
Yes.
Thank you. I thank you.
All right, our next comment is from Michelle Montserrat Ramos. Michelle, you should be able to unmute yourself.
Good afternoon. I am Michelle Montserrat Ramos. David, I would like to thank you for your presentation. Board Member Pines, although I am pleased that you did link this issue of maternal mortality to physicians as well, where is your leadership role on this board surrounding this issue? Where was your leadership role with the NBC when my friend Charles Johnson approached the medical board when his wife Kira died, and her accusation was not just for her, but included harm to 5 women? I am concerned that a public board member is bringing a presentation on maternal health to this board without taking leadership on this issue. When you know that this board is closing complaints for babies of color, denying them a right to an investigation, and also denying them the right to the exception to the statute of limitations for minor children. You are all aware of this because these parents and grandparents have been reporting this issue to this board for the past year and a half. These mothers and babies have not been valued. Their lives and deaths are of no value. It is no secret. We will never begin to curb the maternal mortality crisis in this state until you investigate all maternal deaths, which include infant deaths due to maternal negligence. All these maternal deaths and serious bodily injury complaints that the families have commented on to this board are all linked to maternal negligence. And all of the mothers and babies that have died or have suffered lifelong harm are people of color. I agree with the families that this board must call for an investigation into why board staff is closing these cases without investigation and not following Business and Professions 2230.5D, the exception of minor children guideline, and Public Board Member Pines should be the board member that takes leadership of this issue and calls for this investigation. Really, any of you should call for an investigation into this issue. This is a matter of public safety to the highest degree for all California families. Thank you.
And we have a comment from Xavier De Leon. Xavier, you should be able to unmute yourself. And you're unmuted.
Okay, perfect. My name is Xavier De Leon. I'm from Bakersfield and a volunteer with Consumer Watchdog. And just like everybody before me has said, I really can't believe that Denise Pines would choose to insult us parents by bringing the issue of Black maternal health to this board, when she is choosing to sit by and watch us fight for the rights of our babies who were lost to maternal negligence. She sat there and said nothing when we explained how our babies were denied the right to an investigation and also denied the right to the exception to the statute of limitations for minor children. Denise, you have not only sat on this board in silence, not once speaking up, asking for an investigation into why babies' deaths for maternal negligence are being denied an investigation. You also sat on the medical board when my friend Charles Johnson's wife, Kira's doctor complaint, which included the death and harm of 5 women, was given, and he was only given probation. We expect more from you on this board, especially from our public board members. Ms. Pines, we are calling on you to demand an investigation into the complaints of babies of color. We really are questioning why these complaints are not going into investigation and why these babies of color are being denied the exception of the statute of limitations for minor children. Thank you.
All right, this is moderator. I see no further requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you.
You're welcome.
All right, we'll move on to item number 18 on the agenda, which is future agenda items and future meeting dates. Machiko, you want to go over the dates that we've talked about? Obviously, we have to add, we'll do a survey and see what date works for June, I think.
We do. Currently, we have 2 dates on the calendar. August 17th, down in Southern California at Western University, and December 7th here in Sacramento. And then we have nothing lined up for 2024 as of right now.
Okay.
So we can start off with January. If we want to stick with Thursdays, the 4th, 11th, 18th, and 25th are all Thursdays in January.
And I'd say 18th to 25th from my perspective, but whatever you guys. The second half of January.
Second half of January. 18th?
18th, okay.
Going once.
18 works for me as well.
18th?
18th or the
Is that
25th.
around, is that close to
Oh.
for Federation?
Yeah, I was just thinking, is that close to the Martin Luther King holiday timeframe?
Oh.
What is the holiday? Let's see.
The
Tuesday on the Monday?
15th, right? No.
It'll be after that then.
So then the 25th?
Well, no, which day is Martin Luther King?
I think it's the
Junior
15th. I
holiday.
could be wrong.
It's the 15th.
It's the
15th?
15th. I'm like, I have it on my calendar as the 15th, but
Do you
I
want
could
to
be
do
wrong.
it the following week or that same week?
So it's the 15th, and the date,
Well, it's,
we're talking about
Thursday. The holiday
okay,
is the
so
15th.
I think we're fine. I think the 18th
Okay, so
would be
18th.
fine.
Did you have something, Erica?
The 18th is a Friday. Just want to clarify that. So
It's a Thursday.
17th, are we looking at the
Thursday.
17th?
No.
It's a Thursday. It's a Thursday.
Thursday. We're in 2024.
I'm sorry. Looking at the wrong year. Sorry, Dr. Bahar.
That's okay.
And this is in Sacramento?
Yes. So January 18th, Sacramento. And then if we want to put May on the calendar, unless we want to go April, do we want it April or May for legislative purposes?
Does April tend to be better for that? Terry?
May.
May?
Okay. So,
Okay. Okay.
so we have 4 Thursdays in May 2nd, 9th, 16th, 23rd, or the 30th.
16th is good for me, but I'm open.
You said it will or will not work for you, Gore.
It would work for me. The 16th
It
would
would.
work, but I'm open as well for other days.
16th is fine with me, too. May 16th, 2024?
May 16th.
Objections? No?
Would we like to, maybe we can reach out to Toro and
Yeah.
see if they can host.
Sure.
We'll reach out to the osteopathic universities that are local and see
Yeah.
what works best for their students for outreach purposes.
I think that's a good idea.
What city?
Either Mare Island or Toro or, what is it, Bakersfield? No.
There's one in Modesto.
Modesto, right?
Modesto or
Clovis.
yeah.
Clovis, Clovis
Yeah.
community, yeah.
So I'll reach out to the 3 universities and see what their schedules look like. So we'll do a tentative location, but scheduled for the 16th. How's that work?
Yeah.
Sounds good.
Is May exam time for any of those schools?
That is why I'm placing a tentative location, but we're scheduling it for the 16th. Regardless of where it is, it's going to be the 16th.
Yeah.
It's just based off of what information I receive back. Do we want one more, or do we want to stick with the 2?
Why don't we keep it at that? So that's 4. We're staying 4 ahead right now.
Yeah. Okay.
Yep.
All right.
Any additional items for the agenda? New business that we want?
Yeah, I'd like to add something for the agenda. I'd like to have the staff look at the other osteopathic boards in terms of how many staff they have and salaries that they have for the positions that they have on staff. And then the other thing I'd like to add is looking at this board doing a Hill Day where board members go and meet with our legislators.
And this is Claudia. I won't be here, but I think I can still add things to the agenda. But, some of the comments that the public brought up and that I'm also interested in learning more about, and I could probably attend the meetings as a public or a member of the public then. But there's a lot of talk about the statute of limitations for minor children, and I'm not really sure how that works or what was being implied in terms of how our board takes in cases in our review, if it is a death of children. So I just wanted to have the board address some of the concerns that the public brought to the table today, if possible, with their expertise.
Thank you, Claudia. I believe at our January board meeting, I mentioned that we were going to be reaching out to the Attorney General's office to provide a more in-depth presentation on their specific role. The last board meeting, we had a presentation on the enforcement process, but now we are catering the idea of talking to the Attorney General's office to just give us a more in-depth presentation on just the role of the Attorney General's office, which will then cover the statute of limitations and all of the exemptions that we have. So possibly at our August or upcoming, yeah.
Okay.
But what about June, setting a June teleconference meeting? You want to do that now?
Do you want to set that now, or do you guys want to do a Survey Monkey thing?
We can do it.
I think we can do a Survey Monkey on that and come back. Yeah.
Okay. Yeah. I know the first week of June will be out for me anyways. All right. Well, so you guys will be receiving a survey as to when a good date in June for a teleconference to go over pending legislation, so we can take a stance on some of those items. And with that, we'll move on to agenda. Oh, any comment from members of the public that are here? I see none. Moderator?
I would just like to invite you again next year if you can come and just keep the conversation going. I know you have a relationship, but if you can just keep us informed, we really appreciate it. That's all. Thank you.
Any moderator, any members of the public on WebEx wish to comment on future agenda items and meeting dates?
Thank you, Mr. Board President. I've opened up the Q&A panel. If any member of the public would like to comment on future agenda items or future meeting dates, please type comment using the field in the lower right-hand corner of your screen, or simply raise your hand. We'll give you a moment. All right, I see no requests for comment. Shall I close the Q&A panel?
Yes, please. Thank you.
You're welcome.
All right, item number 19, meeting is adjourned.